Today we're going to talk about transitioning patients from one PAH therapy to another. What are the recommendations regarding transitioning patients? Well, we have really depended on our algorithm in getting patients to a low-risk status to treat patients with pulmonary arterial hypertension, but these medications are complex and have side effects, and there might be many reasons that a clinician might consider transitioning from one PAH-specific therapy to another. One reason might be to improve the side effect profile and convenience or compliance with therapy. Sometimes patients just have a lot of side effects or a lot of pain, and if they're not going to take the medications because the side effects were not doing any good, some of the therapies are very complicated and patients might be doing well, and there might be an easier way to treat them. In patients who are not meeting their treatment goals, transitions are considered to escalate therapy and improve patient status, and this is particularly true of the prostacyclin pathways. And occasionally there are patients who have an extraordinary response to therapy and transition to a less invasive therapy is considered. We think about this sometime, for example, in the patient who comes to us very ill, starts on a parenteral prostacyclin and just has an amazing response, and we can get them to oral therapy. But sometimes the patients are doing so well, we kind of say, gosh, I don't want to rock the boat. We have to be very, very careful about that particular topic. Much of the literature on this topic is retrospective, prospective but observational, or prospective randomized but open label. Patient populations and hypothesis of the studies are quite heterogeneous, and so basically all of this must be interpreted with caution. So in carefully selected patients, the transition from IV epoprostenol to IV treprostinil was achieved about 80% of the time. That was a trial looking at that particular transition really for more convenience because of the longer half-life of treprostinil. Transition from parenteral epoprostenol to the thermostable form was generally achievable, and that was a trial again for convenience because the thermostable form does not require ice packs, so the patients can have a less bulky pump. There were conflicting outcomes in the transition from parenteral prostacyclins to inhaled and oral prostacyclins, and really the key there is that those patients need to be selected very carefully. Overall, for all of these transitions, careful patient selection and extreme caution must be taken in these circumstances. When we do such transitions, we follow patients very, very closely. When due to LFT elevations, transitioning from bosentan to ambrisentan or macitentan is safe, and we've learned this, that ambrisentan and macitentan have less LFT effects on patients over the years, and so that's really much more convenient for them. They also don't need to get their monthly blood test on ambrisentan or macitentan as opposed to bosentan. In the case of lack of efficacy, transition from selexipag or non-parenteral prostacyclin analogs to sub-Q or IV prostacyclins is recommended. And this is the whole concept of driving the patient to low risk. If you start with one of the less invasive prostacyclins like selexipag or like an inhaled agent, and the patient is not improved enough to consider them in the low risk category, the escalation to a more aggressive prostacyclin is appropriate. And there is insufficient evidence to recommend transitioning from sildenafil or tadalafil to riociguat for improving efficacy. There was one small open label trial, and this particular concept is the subject of a randomized controlled trial that is currently ongoing right now. So treatment choices in pulmonary hypertension are quite complicated. We really try to drive a patient into low risk, but once a patient's on therapy, there may be many reasons to consider transitioning. Very little data here, and it has to be done very, very carefully, really in the hands of an expert center that has experience in this because it's such an understudied topic. I hope you've enjoyed our discussion today. Thank you for joining me.